NEETMDS 2024 examinations, there would be subject specific sessions. Okay, the majority of the preparation has already been done, and with the class notes of the different subjects, all you guys must have prepared really well, and we sincerely hope that all of you would perform very nicely and get good ranks in the forthcoming NEETMDS examination. So as a just snapshot of the subject, we have planned a 2-hour series for the subjects, and today, that is on 10th of March, I am starting with the subject of conservative and endodontics. I shall be highlighting some important high yield facts about the subject, some of the topics which are frequently asked in the examinations as compared to the others. We would be discussing that. So it is the predictor series. For cons and endo. Okay. See, during my routine lectures also I have told you that if we talk about the NEET pre-PG examination these days, then majority of the questions they are asked are related to the basics of the subject, whether it is a clinical subject or a non-clinical subject. So if we talk about my subject, that is cons and endo, in endo, the majority of the questions that come are related to the anatomical aspects. They want you to understand the anatomy, the differences in the anatomy, the atypical anatomy that occur. So the first section for today would be about endo. Now in endo, some high yield facts if we talk about. The high yield facts. Okay, the first section, it would consider about the anatomical considerations. Some important anatomical considerations I would tell you. See, anatomical considerations are basically related to the root canal anatomy and its variations. Whenever we talk about the root canal anatomy, one common thing which is asked is the classification of the root canal configurations. So the first thing about is this is Vertusi canal configuration. Vertusi canal configuration. And at times they also ask you about the Wien's canal configuration. These are the two important canal configurations that are frequently asked. According to the Vertusi canal configuration, there are 8 types of canals, and according to the Wien's classification, there are 4 types of canals which are present. Okay, I would quickly summarize what are the types. According to Vertusi, type 1 through 8, they are represented as 1. Type 2 means 2 1. Type 3 Vertusi is 1 2 1. Vertusi type 4 is 2. Vertusi type 5 is 1 2. Vertusi type 6 is 2 1 2. Vertusi type 7 is 1 2 1 2, and Vertusi type 8 finally is configuration 3. Details are already provided in the class notes. Sometimes they do not ask you about the configuration in the numerical form, but they would simply put a figure. I think that would be very easy to identify. Suppose type 1, it is a single canal from the coronal orifice to the apical foramen. Like this they represent it. Okay, if we talk about, on the other hand, the Wien's classification, there are 4 major subtypes according to the Wien's classification. Type 1 is same as Vertusi, that is configuration of 1, a single root with a single canal. Okay, type 2 is configuration 2 1, which is also same as Vertusi type 2. According to Wien, type 3 is configuration of 2, and type 4 is a configuration of 1 2. So they are quite easy and you can summarize and remember them. whether it is diagrammatic or whether it is numerical, it is easy to answer. Okay. Apart from the canal configuration, they also ask you about the atypical canal anatomy. Atypical canal anatomy. So there are different groups of teeth which show atypical or more than regular canal anatomy. Firstly, we talk about mandibular incisors. Okay, in mandibular incisors there is a atypical canal anatomy of two canals. Instead of one, there is an atypical anatomy of two canals, which has a incidence. Numerous times they have asked about the incidence of two canals in mandibular incisors. The incidence would be in the range of 22 to 40%, a comparative high incidence of two canals. And when we have to make a comparison between central and a lateral incisor, okay, mandibular central and lateral incisor, then there are two schools of thought, one according to Cohen and one according to Engel. So it becomes quite confusing, but for your NEET pre-PG examinations, you have to remember what Cohen says, that the incidence of two canals is more for central incisors than lateral incisors. So what I suggest that you stick to this incidence. If the question is asking you about the incidence, which tooth has a greater incidence of two canals amongst the anteriors, then central incisors more than the lateral incisors. Okay. Similarly, if we talk about mandibular premolars, the mandibular premolars, then first premolar, it has the highest incidence of atypical canal anatomy. It has the highest incidence of atypical canals, means more than one canal. At times also contains extra root, not only the extra canal, but they also contain extra root, and this extra root is called Tome's root. So overall, you have to read the question carefully. If they are asking you about the anterior teeth, which anterior tooth has the highest incidence of atypical canals, then it would be mandibular canine. Okay, it would be mandibular canine. If they are asking you about the oral cavity as a whole, of all the teeth in the oral cavity, which has the highest incidence of more than one or atypical canals, then it would be mandibular first premolar. Then another variation amongst the mandibular teeth is found with mandibular first molars. Mandibular first molars, they have two type of variations. One is extra root, which is common, and then there can be extra canal. Extra root, it can be a extra mesiobuccal root, or it can be extra distolingual root. Okay, extra mesiobuccal root is called radix paramolaris. RP is the standard abbreviation. It is called radix paramolaris. So instead of simply asking you about the number of roots, they can give you a radiograph of a mandibular tooth. So you see the radiograph carefully whether the extra root is present mesially or distally. Accordingly, the answer would be radix paramolaris for the extra mesial root and radix entomolaris RE for the extra distal root. Okay, these are the common questions which have come over the years. Then the variation with the number of extra canals. There can be an extra mesial canal or extra distal canal for mandibular first molars. The extra distal canal has an incidence of 30% and an extra mesial canal has an incidence of 1 to 15%. Okay. Then another common variation which occurs with the mandibular teeth in the root canal anatomy is C-shaped canals. C-shaped canals. These C-shaped canals, they have the highest incidence with mandibular second molars. Highest incidence is with mandibular second molars. These C-shaped canals are also found with other groups of teeth like mandibular first molars, okay, maxillary first and second molars, and mandibular first premolar. You can see that mandibular first premolar is a tooth which most often shows anatomical variations, whether it is in the number of roots or it is in the configuration of the root canals. So this tooth, mandibular first premolar, is also called endodontist's enigma. It is a problematic tooth because it can have a high variations in the anatomy. So C-shaped canals, there's a classification for C-shaped canals which is frequently asked. This classification was given by Selzer and Melton. Selzer and Melton. Okay, so there can be type 1 C-shaped canal which is continuous C. Okay, type 2 C-shaped canal is semicolon shape. An add-on feature of this is there are two angles which are defined, that both angles alpha and beta, they are greater than 60 degrees. Okay, type 3 C-shaped canal, it has got 2 or 3 canal openings. Instead of a single C-shape opening, it has 2 or 3 canal openings with angle alpha or beta less than 60 degrees. This is a add-on feature of type 2 and type 3 canals. Then type 4 is a single oval canal. And finally, type 5 C-shaped canal is no canal orifice. Okay, there is just a C-shape groove, but there is just a C-shaped groove without any canal orifice. These are the variations in the C-shaped root canals classification according to Selzer and Melton, and they have the highest incidence among which group of teeth? Mandibular second molars. Okay, then if we talk about the maxillary teeth, then maxillary anteriors, that is central incisors, lateral incisors and canines, they have the least incidence of anatomical variations, whether it is number of roots or the number of canals. Okay, it is with maxillary first premolar that variations are commonly seen. All of you know that maxillary first premolar is a tooth with 2 roots, usually in majority of the cases, but there can be incidence of 3 roots, and this third root has an incidence of 6%. Okay, then if we talk about maxillary first molar, maxillary first molar has a tooth which shows variations in the form of extra root. Most of time there are variations in the form of extra palatal root. Usually a tooth has 3 roots, mesiobuccal, distobuccal and a palatal, but extra root can be an extra palatal root, and according to the location of this extra palatal root, it can be either mesial or distal, just like the extra root of mandibular first molar. Okay, if it is mesial, it is called RML, that is radix mesiolingualis. If it is distal, it is called RDL, that is radix distolingualis. Okay, Then there can be variations in the form of extra canal. Okay, extra canal, the most common variation is MB2 canal, which has an incidence of greater than 90%. Greater than 90% incidence, majority of the cases. A new classification or new nomenclature for mesiobuccal canal, second MB2 canal, which is called MP or mesiopalatal canal. So if the question is asking what is mesiopalatal canal, do not get confused. It is same that is MB2 canal. MB2 canal has a new, I would say, nomenclature, and it is called mesiopalatal canal, and it has an incidence of greater than 90%. In majority of the teeth it would be found. There can be an extra distal canal, distobuccal canal, which is sometimes called DB2, incidence of 1 to 9%. This is relatively rare as compared to this. Okay, these are some of the anatomical variations in the groups of teeth as regard with their canal anatomy. Then there is one anatomical feature if we talk about anatomy of root apex. Anatomy of the root apex. Okay, I'll quickly draw the root apex for you guys. Okay, this is the root apex. Then it has got three features. One is the apical foramen, which is called the major diameter. Okay, then there is apical constriction, AC or apical constriction, which is called minor diameter. Lot of questions they ask about the anatomy. And then there is a third feature, anatomical landmark, which is called CDJ or cemento-dentinal junction. Cemento-dentinal junction is the point at which the pulp tissue ends and the perial tissue begins. Okay, so it is the ideal point for apical termination of root canal procedures. What is meant by root canal procedures? Root canal procedures means your working length determination, the cleaning and shaping and obturation would all ideally should rest at what? Terminate at CDJ, that is cemento-dentinal junction. Okay. Most of the cases, whenever we do clinical endodontics these days, we determine the working length by a non-radiographic method, that is electronic apex locator, isn't it? EAL is the most frequently used device for working length. And EAL is a device that detects the apex. It gives the apex reading whenever the file reaches the major diameter or apical foramen. So if the question is asking you what does apex or reading 0.0 on an electronic apex locator indicate, it indicates the apical foramen, because electronic apex locator technically detects the point of continuation of PDL. Okay, it measures the resistance between the PDL and the oral mucosa. So when the file is touching the PDL, it would record apex. So the reading apex indicates what? Apical foramen. Okay, so you have to always subtract a safety factor of 0.5 to 1 millimeter from the reading of electronic apex locator, so that you do not encroach upon the PDL. Now there is a space between the apical constriction and the apical foramen. This is a fan-shaped space. This space between apical constriction and apical foramen is defined as funnel-shaped, hyperbolic in shape, or shape of morning glory. Shape of morning glory, hyperbolic, or funnel shape. These are the three terms which are used to define the shape of space which exists between apical constriction and apical foramen. This apical foramen, its size increases with age, the anatomical variation. So whenever we have to study the anatomy of the root apex, these three features are present. Then midroot considerations. We'll talk about midroot anatomy. Midroot anatomy has an important anatomical feature called isthmus, which is also called anastomosis. Isthmus or anastomosis. Okay, they are connections between the two canals which exist in the midroot area. They were classified by Kim into 5 types. They also give you questions whether it is figure based or simply theoretical questions. Okay, type 1 isthmus is represented as an incomplete connection between two canals. Type 2 isthmus is a well-defined and complete connection between two canals. Type 3 is a very short but complete connection between two canals. It is a very short but complete connection between two canals. Type 4, there are 3 or more canal openings with either complete or incomplete connections between them. Okay, these 3, there are 2 canals. There are 3 or more canals with complete or incomplete connections between them. And type 5 isthmus indicates 2 or 3 canal openings without visible connections. So this is the anatomical classification of isthmus. They are narrow ribbon shaped spaces that exist between two canals or more canals in a single root. They are connections or bridge between the canals. So they are classified into 5 types. Fine. These are some of the important anatomical variations and anatomical landmarks related to the anatomy of the root, the midroot considerations, the apical root considerations, and also whatever we see about the canal configurations and their variations. Okay, these are the anatomical aspects. Secondly, they ask you questions about the structure and functions of pulp complex. Structure and functions of pulp complex. Okay, so if we talk about the pulp, it is organized into 4 layers. Organization of pulp: outermost, which is the first layer, is odontoblast layer. Okay, this odontoblast layer outlines the pulp from the crown to the root portion. Okay, this odontoblast layer, it secretes dentine, and whenever we find nestin, it means the tissue that is being formed is dentine. So nestin is the compound that is the histological marker of dentine. It is a histological marker of dentine. So odontoblasts are basically cells like this, and they have got 3 type of connections. Outermost layer of pulp, they have got 3 type of connections between them. 3 type of connections between the odontoblast. They are gap junctions, which are also called nexuses. They are made of protein called connexin. This question has also been asked a couple of times. Which is the protein which makes up the gap junctions present between the odontoblasts? So the protein is connexin and the gap junctions are called nexuses. The second type of connections is tight junctions. Tight junctions, they are also called zonula occludens, and there are desmosomes, which are called zonula adherens. These are the three type of connections which exist between the outermost layer of dental pulp, which is called the odontoblast layer. It has a function of secreting dentine, and histological marker of presence of dentine is the compound called nestin. The tight junctions, they regulate permeability. They regulate the permeability of your odontoblast layer. Okay. Then the second layer from outside to inside is cell free zone, which is also called Weil's zone. The third layer from outside inside is cell rich zone, which is also called cell rich zone of Hohl, HOHL. This cell rich of zone of Hohl consists of various cells called fibroblast, which are the most abundant cells of dental pulp. Fibroblast. These fibroblasts principally secrete collagen. Collagen type 1 and type 3 is secreted by what? Fibroblast. Then the cell rich zone also consists of undifferentiated mesenchymal stem cells. UDMSC stands for undifferentiated mesenchymal stem cells. All these stem cells are multipotent. Okay, what type of stem cells are present in the dental pulp? They are the multipotent stem cells. Okay, there are 5 types of these undifferentiated mesenchymal stem cells usually present. One is stem cells of apical papilla. SCAP stands for stem cells of apical papilla. They are the most abundant or rich source of stem cells. Okay. Then we have dental pulp stem cells. DPSC stands for dental pulp stem cells. Bone marrow mesenchymal stem cells. MSC stands for mesenchymal stem cells. BM stands for bone marrow. Bone marrow mesenchymal stem cells. We have stem cells of exfoliated deciduous teeth. Stem cells of human exfoliated deciduous teeth. Stem cells of human exfoliated deciduous teeth, and we have periodontal ligament stem cells, PDLSC, periodontal ligament stem cells. So there are different locations of the presence of multipotent stem cells. All of these cells which are present are multipotent stem cells. Okay, and one of the richest source out of these 5 sources is stem cells of apical papilla. They are very resistant to the hypoxia, and they can be very easily used for regenerative endodontic procedures. So which group of cells are most abundantly found? They are the stem cells of apical papilla. Okay. Then it also consists of cells like fibroblast. We have talked about mesenchymal stem cells. Then there are APC, that is antigen presenting cells. In the cell rich zone, there are macrophages and there are lymphocytes. These lymphocytes are of 2 types, B and T lymphocytes, but the pulp does not contain B lymphocytes. It is the T lymphocytes which are present. They are the immune cells, and there are mast cells. Mast cells are present only in inflamed pulp and not on normal pulp. So whenever we talk about pulp inflammation or inflammation anywhere in the body, you know that whenever inflammation is there, mast cells would come, and these mast cells contain granules. They release two compounds, H and H. You can remember that like that: histamine and heparin. Histamine causes vasodilation and heparin causes anticoagulation. So whenever there is inflammation of the pulp and we enter such pulp, the pulp bleeds copiously because there is no mechanism to coagulate the blood because of the presence of heparin released from the granules of mast cells. There is copious blood supply because of vasodilation induced by histamine. So whenever inflammation of the pulp is there, there would be vasodilation and anticoagulation. So because of these, the pulpal pressure rises. Increases. In cases of pulpal inflammation, the pulpal pressure increases. So what is the pulpal pressure in an inflamed pulp? It is in the range of 30 to 35 millimeters of mercury for an inflamed pulp. For normal pulp, what is the intrapulpal pressure? All of you must be knowing 10.2 millimeters of mercury, or sometimes 14 centimeters of water column. This is the intrapulpal pressure for normal pulp. It rises to almost 3 times, 30 to 35 millimeters of mercury. So questions have come both. They can ask you the normal pressure of the pulp, either in millimeters of mercury or centimeters of water. They can ask you the pulpal pressure in the cases of inflammation. So the respective values are given over here. Then the third layer, from outside to inside, we are discussing the structural organization of the pulp. The fourth layer is pulp proper. The innermost layer of the dental pulp is called pulp proper. It is basically a loose connective tissue. So what type of tissue is dental pulp? It is a loose connective tissue. It consists of numerous blood vessels, nerve fibers, and cells. What are the cells? Cells we have already discussed. What are cells present in the dental pulp? And the highest number of such cells are present in which zone? The third zone, that is the cell-rich zone of whole. The nerve fibers of the dental pulp. There are two groups. One is the sensory fibers, which carry the sensation. They are also called afferent fibers. Okay, and there are autonomic fibers. Autonomic fibers, all of you know that they consist of two types of nerves. They are sympathetic and parasympathetic, isn't it? But the occurrence of parasympathetic nerve fibers in the pulp is not well documented. We can say they are best absent from the dental pulp. It is the sympathetic nerve fibers which are present and the sensory nerve fibers which are present. So two types of nerve fibers are present in the dental pulp. The sensory fibers, they are derived from the trigeminal nerve. Trigeminal nerve, all of you know, is the fifth cranial nerve, which is a mixed nerve. It gives sensory innervation to the dental pulp. Sympathetic fibers, they are derived from superior cervical ganglion. They arise from superior cervical ganglion, which is the ganglion of trigeminal nerve, and they are distributed via internal carotid nerve. They are distributed via internal carotid nerve. So this is about the innervation of dental pulp. Sensory fibers, two types of sensory fibers are present in the pulp, A and C fibers. A fibers, they are myelinated. They consist of 20% of the pulpal nerve fibers. C fibers are non-myelinated and they make 80% of the pulpal nerve fibers. Okay, A fibers are further of two types which are present in the pulp. Sensory, as the name indicates, they carry the sensations from the dental pulp to the brain. Okay, A fibers are A beta fibers and A delta fibers. 10% of the A fibers are A beta fibers and 90% of the A fibers are A delta fibers. A beta fibers, they carry the sensation of pressure. We can say proprioception. They sense pressure. A delta fibers carry the sensation of pain, temperature and touch. Okay, and C fibers, which are the 80% fibers, they carry the sensation of only pain, so we can say that they are principal nociceptors. What type of pain is carried by A delta nerve fibers? A delta nerve fibers, they have the quality of pain which is short and sharp pain. Okay, the quality of pain which is conducted by C fibers is dull and throbbing pain. So they have difference in the characteristic of pain being carried. A dull throbbing pain carried by C fibers is less bearable as compared to A delta fiber pain. Now these fibers, some are myelinated, some are non-myelinated, so they are fast and slow conducting. A beta fibers, which are proprioceptors, they are the very fast conducting. 30 to 70 meters per second is the conduction velocity for them. A delta nerve fibers, this is what? Conduction velocity. Velocity for them. A delta fibers, 6 to 30 meters per second have conduction velocity, and C fibers are the slow conducting, 0.5 to 2 meters per second is the conduction velocity for them. Okay, these are the three type of sensory fibers present in the dental pulp and their characteristics. Now we talk about blood supply. Blood supply to the dental pulp is from maxillary artery. This maxillary artery is a branch of external carotid artery. Okay, the resting rate of blood flow to the dental pulp is 15 to 60 ml per minute per 100 gram tissue. The rate of blood flow in a resting state to the dental pulp is 15 to 60 ml per minute per 100 gram of tissue. Figure is per 100 gram of tissue. If it is asking about per gram of tissue, just divide it by 100, you will get the answer. Similarly, because of blood flow, there is oxygen consumption by the pulp. So rate of oxygen consumption is 3.2 plus minus 0.5 ml per minute per 100 gram tissue. These are some of the important aspects of pulp blood circulation, which is derived from the maxillary artery, a branch of external carotid artery. Okay, this is the structural organization of pulp and their related aspects, whether it is the cellular organization or the innervation or the vasculature of the dental pulp. Okay, sometimes they ask you about deafferentation. Deafferentation. What are afferent fibers? They are the sensory fibers, means we have removed the sensory nerve fibers. So deafferentation or phantom tooth pain. Phantom tooth pain. It is a molecular phenomena which happens that after root canal there is persistent pain in a patient in which no other reason can be found, is defined as deafferentation, which has a incidence of 3 to 6%. And what is the reason for this persistent pain? There is upregulation of CFOS gene. There is a particular gene CFOS, FOS, which is present on the pulpal nerve fibers. Okay. Sometimes because of cases of irreversible pulpitis, the teeth, they do not get numb with local anesthetic. LA stands for local anesthetic. In cases of irreversible pulpitis, or we can say symptomatic irreversible pulpitis, the local anesthetics fail to act on the teeth. What happens to these sensory nerve fibers? The sensory nerve fibers of teeth with symptomatic irreversible pulpitis, they become tetrodotoxin resistant. They become tetrodotoxin resistant and they are represented as TTXR nerve fibers. Okay, such teeth with symptomatic irreversible pulpitis which cannot be anesthetized with local anesthetics, they are called hot teeth. So basically two set of questions. What are hot teeth? Hot teeth are teeth which consist of tetrodotoxin resistant nerve fibers. And what type of teeth show these tetrodotoxin resistant nerve fibers? They are the teeth with symptomatic irreversible pulpitis. Okay. And what are the tetrodotoxin resistant nerve fibers? They are the particular group of nerve fibers with sodium channels. All of you know that local anesthetics act by blocking the sodium channels present on the nerve fibers, isn't it? The basics of your pharmacology. So there are 9 subtypes of sodium channels, 1 through 9. Out of these 9 subtypes, the subtypes 8 and 9, they are tetrodotoxin resistant sodium channels. So another set of question, what are tetrodotoxin resistant sodium channels present? They are subtypes 8 and 9. Out of 9 subtypes of sodium channels on the nerve fibers, the subtypes 8 and 9 are tetrodotoxin resistant. And such teeth are called hot teeth. For treatment of hot teeth, we do pre-medication with non-steroidal anti-inflammatory drugs. Which non-steroidal anti-inflammatory drugs? According to the order of potency, the most potent is ibuprofen. High dose of 600 to 800 milligram TDS. The second drug in order of potency is ketorolac-tromethamine, 10 milligram TDS, or simply Ketorol DT. DT stands for dispersible tablet. And the third drug in the order of potency for such teeth is acetaminophen. Acetaminophen, that is paracetamol, again in high dose of 1000 milligram. So these are the 3 drugs in their decreasing order of potency for treatment of such teeth, pre-medication with non-steroidal anti-inflammatory drugs. Okay, this is the pathophysiology related to the sensory nerve fibers present in teeth with symptomatic irreversible pulpitis. Okay. Thirdly, there are questions on instruments. Okay, there are 2 sets of instruments, both endo instruments and conservative instruments. If we talk about the endodontic instruments, they ask you about the generations of nickel titanium instruments. I am just telling you the high yield facts related to the subject of endo. Generations. There are 5 generations of these rotary nickel titanium instruments, or we say simply nickel titanium instruments. The first generation, they are passive cutting with radial lens. Means they have blades with thick radial lens. These are the thick blades with radial lens, so they are passive cutting. Okay, they are U-shaped cross section. U-shape in cross section, and we have to talk about the example. There are 3 examples you can remember: profile, okay, GT files, and light speed. Light speed is an exception to nickel titanium rotary instruments in which it has a speed of rotation of 1500 to 2500 rpm. Otherwise, all other nickel titanium rotary instruments generally they have a speed range of 150 to 300 rpm. This is for generally all groups of nickel titanium instruments. The light speed you can remember as an exception. That's why they are called light speed. They rotate very fast. Okay, so if the question is simply asking you what is the speed range of rotary nickel titanium instruments, answer would be 150 to 300 rpm. If it is asking specifically about light speed, the answer would be in this range, 1500 to 2500 rpm. And the better answer is this: if they are as separate choices, both 1500 and 2500 are as separate choices, stick to 2500. The second generation of nickel titanium instruments, they are active cutting, which do not have radial lens. They would be having sharp blades like this without radial lens. So they are active cutting. Example of instruments, prominent ones are taper, okay, M2, endo sequence, which is also called real world endo, race, hero. Okay, these are the prominent examples of active cutting instruments which have got blades with sharp edges, so they cut very aggressively. The third type of instruments, they are special heat treated. They are special heat treated nickel titanium instruments. Special heat treated examples: Highflex, CM, okay, twisted file. These are prominent examples of special heat treated. The fourth generation, they have alternate motion of use. Alternate motion of use. What is meant by alternate motion of use? Means instead of rotating, they would either reciprocate or they move up and down. Means they do not rotate inside the root canal. Example of instruments which reciprocate are wave 1 and reciproc. Up and down is self-adjusting file. SAF stands for self-adjusting file. And finally, the fifth generation of instruments, they have off-center design. Off-center design. Off-center design, they are represented like this: an instrument with a blade cross section, and this is the axis of rotation. axis of rotation. And because of their off-center design, these instruments, they have motions like swaggering motion. The motion is called swaggering motion or snake-like motion. Sometimes they just give you a figure like this and want you to identify the generation of nickel titanium instrument. You can clearly see that the axis of rotation is not passing through the center of the blade, but it is off center. So these instruments are specially designed in the way that they do not rotate at the center of the mass, and they have eccentric rotations. That's why they are called off center designs. And when they rotate in the root canal, the motion is called swaggering motion or snake-like motion. Example: ProTaper, Next, True Shape, and Revo S. These are three prominent examples of fifth generation of nickel titanium instruments. Okay, so they simply give you the names of the instruments, want you to identify the generation. They can give you a figure, or they can simply ask you about how do they work. Okay, commonly asked questions about them. Then related to the instrumentation, they would ask you about lasers and applications. Straightforward questions related to lasers and applications. Lasers simply classified into three types based upon their wavelength. Okay, ultraviolet lasers, which are also called excimer lasers. Okay, visible light lasers and infrared lasers. What you have to do, you have to remember their wavelengths. Excimer lasers are argon fluoride, krypton fluoride, and xenon chloride, wavelengths of 198 nanometers, 248 nanometers, and 308 nanometers. All these wavelengths are in nanometers. Okay, these excimer lasers, they are absorbed by hard tissues. Dental hard tissues. Okay, in the oral cavity, two type of tissues are there: soft and the hard tissues. So whichever tissue absorbs the energy of the laser is the classification for that lasers. There are certain lasers whose energy is absorbed by the soft tissues like oral mucosa, gingiva, etc. So they are designated as soft tissue lasers. Some laser energy is absorbed by the hard tissues like dentine, enamel, cementum, or the bone. They are designated as hard tissue lasers. So excimer lasers, they are absorbed by the hard tissues. So they are useful in cutting the dental hard tissues. The visible lasers, commonly one, are the argon laser, wavelength of 490 nanometers, which is also used for curing of composites. Okay, then we have KTP laser, potassium titanyl phosphate, wavelength of 532 nanometers, and we have diode lasers, which are mostly red lasers. Okay, solid state lasers. Red laser would be having wavelength in the range of 620 to 690 nanometers. All of you know that visible spectrum is in the range of 400 to 700 nanometers. This is the full visible spectrum, isn't it? So any laser which has a wavelength in between 400 to 700 nanometer would be designated as visible laser, and the important visible lasers are these. Diode laser is particularly useful in the case of photoactivated disinfection. Photoactivated disinfection of the root canals, okay, which is designated as PAD, light activated therapy, or photodynamic therapy, or photoactivated disinfection, which consists of two parts. One is a photosensitizer. A photosensitizer dye, which is TBO, that is toluidine blue. Toluidine blue. So we inject the dye inside the root canal which stains the bacteria and microbes present, and then we use a red diode laser. So question is asking you, in photoactivated disinfection, what is the wavelength of light that is used for disinfection of the root canal? So what would be the answer? Red diode laser is in the range of 620 to 690 nanometers. Indirectly they are asking you, in photoactivated disinfection, the wavelength of laser used. Finally we have infrared lasers. Infrared lasers means wavelength more than 700 nanometer. The common examples are ND-YAG laser, wavelength of 1064 nanometers, carbon dioxide laser 10,600 nanometers, the longest wavelength, which is the longest wavelength of the lasers. We have two erbium lasers, erbium YAG and erbium chromium YSGG, which is also called water laser. The respective wavelengths are 2940 nanometers and 2790 nanometers. Okay, these erbium lasers, they are most efficient to cut dental hard tissues. Just now we have seen that there are two types of tissues, hard and soft tissues. So two lasers can be used for hard tissues. One are the excimer laser, another the erbium lasers. Out of them, the most efficient for removing the dental hard tissues are what type of lasers? The erbium lasers. Okay. Then we have holonium YAG laser, wavelength of 2100 nanometers. These are the principal examples of your infrared lasers. Erbium YAG laser, apart from cutting the dental hard tissues, has additional applications. Okay. Firstly, it is used for shaping of root canals. Shaping of root canals in the form of RC lasers. RC simply stands for root canal laser, which is a side firing laser tip. Okay. And another application of this erbium YAG laser is light walker. Light walker device. Light walker is basically PIPS. PIPS stands for photon induced photoacoustic streaming. Photon induced photoacoustic streaming. Okay, so what laser do we use in PIPS and in I would say in shaping of the root canals? Erbium YAG lasers. Okay, both erbium YAG lasers are used. Light walker is the brand name and PIPS is the technology, that is photon induced photoacoustic streaming. An advanced form of PIPS is sometimes also called sweeps. Okay, sweeps stands for shock wave emission enhanced photoacoustic streaming. Both of them are the technologies that use erbium YAG laser. Okay, so question is asking you what wavelength or is used in PIPS or sweeps technology. Answer would be 2940 nanometer or the erbium YAG laser. Light walker is the name of the device which works on PIPS and sweeps principle, and they are used for disinfection of the root canals by agitating the liquid, that is sodium hypochlorite, by way of laser energy. Okay. Then another application of laser is pulp diagnosis. In pulp diagnosis, there are two main streams of laser application. One is laser Doppler flowmetry, LDF. LDF is the most accurate method of pulp vitality testing, okay, which uses helium neon laser of 632.8 nanometers. So it would be definitely a red laser, visible laser is used. Okay, 400 to 700 nanometers is what? Your visible wave spectrum. Second application is pulse oximetry. Pulse oximeter has become a household device after the COVID. Almost everyone would be having pulse oximeter. So pulse oximetry basically uses two type of lasers. One is infrared of 940 nanometers and other is red of 640 nanometers. Pulse oximetry, basically it measures blood oxygen saturation. Okay, and it is based on Beer-Lambert law. So there are questions which have come on all these things. What is LDF? What is pulse oximetry? So most accurate method for diagnosing the pulp vitality is LDF. So you have to look for the options given. If LDF is given for the vitality testing, it is the first choice answer. Only exception is for free graft. Whenever it is a free graft not attached to the tissue, so the best method is prick test. To assess the vascularity of a free graft, it is the prick test. We would pierce it and see whether there is blood circulation or not. Otherwise, for all other situations, laser Doppler flowmetry is the best diagnostic method for assessing the vitality of blood circulation in the tissues. Okay, these are some of the common applications of lasers. Another is caries diagnosis. Use of lasers. We use a device called Diagnodent. Diagnodent that is based on the principle of QLF, that is quantitative laser fluorescence. Quantitative laser fluorescence. Okay, Diagnodent, it uses green laser for a normal tooth and a carious tooth emits red color. Diagnodent. So another application of lasers in the field of conservative and endodontics. Then we use them in treatment of dentinal hypersensitivity. Use of lasers in treatment of dentinal hypersensitivity. We use lasers like KTP or NDEG laser. One is infrared, one is visible laser. Okay, what is the mechanism? They block conduction of pulpal C fibers. So which fibers are affected by the laser energy? There are two types of sensory nerve fibers, A delta and C fibers, which conduct the pain. So it is the C fibers whose conduction is blocked, and this is a reversible blockage for up to 4 months. It's not a permanent solution but a reversible blockage of conduction of pulpal C fibers by lasers like KTP and DEG. So these are the laser wavelengths and the common applications. Then other common questions which are being asked, they are related to tooth resorption. tooth resorption, and trauma. Tooth resorption and trauma frequently asked in cases of your exams. So tooth resorption, basically three type of tooth resorptions we encounter. One is external inflammatory resorption. The standard abbreviation is there, EIR, that is external inflammatory resorption, internal root resorption, and external cervical resorption, ECR. Inflammatory, external resorption, internal root resorption, and external cervical resorption. Okay. If we talk about their etiologies, external cervical resorption, there is damage to, external inflammatory resorption, there is damage to pre-cementum. Internal root resorption, there is damage to predentine. They are the prerequisites. Pre-cementum is the outermost non-mineralized layer which covers the cementum. Predentine is the innermost non-mineralized layer which covers that dentine. ECR, also there is damage to pre-cementum, because external damage to the pre-cementum, internal damage to predentine. Mostly in cases of trauma, internal root resorption is mostly because of trauma and caries. External cervical resorption is mostly due to ortho treatment and non-vital bleaching. So there are certain differences in their etiologies. Clinical symptoms. Clinical symptoms, all the three are relatively asymptomatic. Unless there is secondary infection, all the three forms of resorption are asymptomatic. Radiographically, radiographic signs are evident in cases of external inflammatory resorption in 1 to 2 weeks as loss of lamina dura. Internal root resorption is radiographically available as fusiform enlargement of root canal. Fusiform means if this is a tooth, the root canal in the tooth would be enlarged like this, a bulbous fusiform enlargement of the root canal, okay, through which canal outline not visible. We cannot see the outline of the canal through the lesion. It is an important diagnostic sign. Okay, in cases of external cervical resorption, there is radiolucency superimposed on root canal. Radiolucency superimposed on the root canal means the canal outline is visible. Through the defect. So this is the main difference between internal and external cervical resorption in their radiographic appearance. The canal outline is visible with external cervical resorption and not visible with internal root resorption. If we talk about their treatments, then definitely pulpectomy and root canal therapy. Removal of the infected pulp and root canal therapy halts the external cervical resorption. Internal root resorption also requires pulpectomy in RCT with obturation method, a specific obturation with thermoplasticized gatta parcha, because liquid gatta parcha in thermoplastic technique fills the defect of internal root resorption very well. For external cervical resorption, we have to remove fibro-osseous tissue with 90% trichloroacetic acid. Fibro-osseous tissue, which is formed in the cervical region of the tooth that enhances the resorption of the tooth from the cervical region, has to be removed by dissolving it in 90% trichloroacetic acid and then followed by restoration of the cervical defect. So these are the treatment alternatives for these three types of resorptions. Now we talk about trauma. Trauma can affect the crown, it can affect the root, or it can result in avulsion of the tooth. Okay. Crown fracture can be involving only the enamel. It can be involving enamel and dentine, and it can be involving the enamel, dentine and pulp, exposure of the pulp. Root fracture can occur, if this is a root, can occur in the apical, middle or cervical 1/3. And avulsion means complete articulation of the tooth. So if we talk about the crown fracture first, then only of enamel requires simple restoration. Enamel and dentine also requires restoration. Whenever there is involvement of enamel, dentine and pulp, it requires root canal if the duration is greater than 48 to 72 hours. EDP stands for exposure of enamel, dentine and pulp. Root canal has to be done if the trauma has occurred more than 48 to 72 hours. Otherwise, pulpotomy, that is removal of the corneal pulp, if less than 48 to 72 hours. This is the distinction, because whenever there is a fresh trauma, the pulp is not fully inflamed, there is no need to remove the entire pulp from the root canal. If we talk about root fractures, the root fractures most favorable, they are apical 1/3. Usually they require no treatment. If they are asymptomatic, they require no treatment. Only treatment required is splinting. Splinting in the cases of root fractures or any other form of trauma is always semi-rigid. Semi-rigid splinting is also called physiological splint. Okay, semi-rigid or physiological splint, and the duration is 2 to 4 weeks. Previously it was 2 to 4 months, but the current International Association of Dental Traumatology guidelines say that they have to be splinted only for 2 to 4 weeks. Okay, middle 1/3 fracture, if this is the tooth, fracture in the middle 1/3, then the treatment involves RCT of coronal portion. Okay, after apexification, we will do an apical plug formation in the coronal portion and the filling root canal of the coronal portion only. We do not go through the fracture and do any treatment with the apical 1/3. If the apical 1/3 becomes infected or there is a periapical lesion, we have to manage it surgically. If there is no periapical lesion, there is no need to do anything with the apical segment, and What important is that root canal procedures are always done in the coronal portion only. Splinting would definitely be required. It is the same splinting as apical 1/3, that is semi-rigid for 2 to 4 weeks. Okay, the least favorable type of root fractures are cervical 1/3. They are the least favorable. The prognosis is really poor, and we have to do splinting for 2 to 4 months. Instead of weeks, the splinting duration is increased to 2 to 4 months. Okay, this can be at times rigid splinting. Because the fracture segment would be highly mobile, we can do rigid splinting for 2 to 4 months, and since the root portion is not involved, the physiological splint is not required in such cases. Rigid splinting for 2 to 4 months is done. Pulp necrosis. It occurs in 25% cases of root fracture. So root canal is not always required. Only if the tooth is non-vital and not responding to your pulp testing methods, we have to do the root canal. And how the root canal would be done, we have discussed for the location of the fractures accordingly. Radiographs. For diagnosis, we have to take radiographs. 3 angle radiographs are required: 90 degrees, 110 degrees, and 145 degrees. 3 vertical angulations are required for exposing the radiograph of cases of root fracture radiographic evaluation. Okay, these are the different aspects on which questions have come. Then avulsion. Is complete removal or exarticulation of the tooth. Avulsion. Avulsion treatment methods include storage medium. The storage medium: wire span, HBSS, which is also available in the trade name of Save a Tooth, Hank's balanced salt solution, cold low fat milk, saliva, and water. From most favorable to least favorable, these are the storage mediums. The ideal or optimal time for avulsion, which results in favorable prognosis with the treatment, is 15 to 20 minutes for replantation. Okay, and maximal time after which the survival is least likely is 60 minutes. In such cases, depends upon 2 factors. The first factor is maturity status of tooth. And second is extraoral dry time. How much time the tooth has been out of the oral cavity. So maturity status, it can be a closed apex tooth fully formed which has avulsed, or it can be an immature or open apex tooth. Extraoral dry time can be less than 60 minutes. Ideal time is 15 to 20 minutes, but an average time as a reference is 60 minutes, or it can be more than 60 minutes. So treatment depends upon these two factors which determine the treatment. Okay, in the first scenario, when the dry time is less than 60 minutes with closed apex, Okay, at times they would give you questions with the age of the patient and not mentioning the closed or the open apex. Then you have to remember about your knowledge of dental histology and dental anatomy, that what is the eruption time of the different sets of teeth and what is the maturity status of the root. So if they are asking about the simply age, from the age of the patient you can determine whether it is closed or open apex. Dry time less than 60 minutes, closed apex tooth, it has a favorable prognosis because the time is less. Favorable prognosis. Okay, replant the tooth. Okay, and then splint the tooth. Duration of splinting in cases of all kind of avulsion is 7 to 10 days, or I would say 1 to 2 weeks. Okay, and this is always semi-rigid or physiological splint. Semi-rigid or physiological splinting is done. Okay, avulsion happens with alveolar bone fracture. There is not only tooth avulsion but the fracture of the alveolar bone. Then the splinting duration is 6 to 8 weeks. Okay, so read the question simply asking you about the avulsion or avulsion with alveolar bone fracture. Then the duration of splinting varies. The type of splinting always remains the same, that is physiological or semi-rigid splinting. Okay, we do RCT because whenever avulsion occurs, the pulp necrosis is inevitable. So root canal is done at the earliest. To prevent external inflammatory resorption. If we do not do root canal and simply replant the tooth, what would happen? The necrotic pulp would initiate external inflammatory resorption. So root canal is done within 1 to 2 weeks after replantation. There is no need to do it immediately at the first visit. Second scenario is dry time of greater than 60 minutes with a closed apex. Fully formed tooth out for more than 60 minutes, then this is an unfavorable situation. Okay, we have to treat the tooth, treat root with citric acid 50% for 1 minute. This removes the PDL from the root. Okay, because the necrotic PDL would initiate an inflammatory response, lead to resorption of the tooth. We have to prevent that because the time is more than 60 minutes. There is no point of replanting the tooth directly. We have to remove the PDL from the root surface by treating with an acid. Then 5 minutes with stannous fluoride. It helps in conditioning of the root. Then we replant the tooth and splint it. Duration of splinting remains the same, 7 to 10 days or 1 to 2 weeks as we have discussed above. If there is alveolar fracture, 6 to 8 weeks is the duration. Okay, followed by root canal. RCT 1 to 2 weeks later. Third clinical scenario is an open apex tooth with time less than 60 minutes. Okay, we replant the tooth and attempt regenerative endodontic procedures. REP stands for regenerative endodontic procedures or apexification. Definitely splint would be there. What is the duration of splinting? Same, no change. The least favorable type is open apex with greater than 60 minutes duration, okay, it is the least favorable prognosis. Least favorable prognosis. Okay. Failure of replantation mostly occurs with external inflammatory resorption, and success is considered to be tooth ankylosis. So whenever there is case of avulsion, we consider majority of the failures with external inflammatory resorption, which is also called tooth resorption simply, and tooth ankylosis, which is also called replacement resorption. If there is replacement resorption, the tooth would remain inside the oral cavity but fixed to the bone. It is considered to be the treatment success. Failure is external inflammatory resorption. These are the important aspects about your dental traumatology. Okay, a lot of questions come. Another subset of trauma is your luxation injuries. Luxation injuries, they are categorized as concussion, okay, subluxation, lateral luxation, extrusion, and intrusion. 5 types of injuries are there which are categorized as luxation injuries. There are 3 things: displacement, mobility, and pain on percussion. D stands for displacement of the tooth, M stands for mobility of the tooth, and P stands for pain on percussion. Whenever there is concussion, there is no displacement of the tooth, there is no mobility, simply pain on percussion is there. In cases of subluxation, there is no displacement of the tooth, but the tooth has increased mobility and there is pain on percussion. Whenever there is case of lateral luxation, there is displacement of the tooth in either of the 4 directions, that is buccal, lingual, mesial, or distal. There is mostly no mobility of the tooth because the tooth has become lodged in the bone. The tooth moves into its socket and is lodged in the bone, and there may or may not be pain on percussion. Extrusion, there is displacement of the tooth in an coronal direction. There is mobility of the tooth and there is usually pain on percussion. Intrusion, there is displacement in the apical direction. There is no mobility because the tooth becomes lodged in the bone and there is pain on percussion. So these are the 3 clinical signs that we have to look for: displacement, mobility, and pain on percussion and their respective features. Whenever the tooth becomes lodged in the bone, as in the case of lateral luxation and in the case of intrusion, the tooth has displaced but has become lodged in the alveolar bone, there would be high-pitched metallic sound on percussion because of the sounding of bone. Okay, so concussion is the least and the most favorable form of luxation injury. Intrusion is the most severe form of injury. For intrusion, the splinting time is 2 to 4 weeks, again semi-rigid or flexible splinting. Extrusion and lateral luxation, the splinting time is 2 weeks. Okay. In subluxation cases also 2 weeks. So these are the duration of splinting, and the type of splint always remains the same. The only exception is a rigid splint with the cervical 1/3 root fracture, 2 to 4 months. These are about the traumatology aspects of endodontics. Then endomicrobiology, they also ask you questions. Endomicrobiology. In endomicrobiology, you have to remember that root canal infections, they can be of two types: intraradicular and extraradicular. As the name indicates, intra and extraradicular, from outside the root or from inside the root. Intraradicular is a more common type of root canal infection. These are again categorized into three principal types. One is the primary infection of the root canals, secondary infection of the root canal, or persistent infection of the root canal. Okay, primary, secondary, and persistent infections. Primary infections of the root canals, they are dominated by anaerobes. Okay. Secondary infections of the root canal. Secondary infection means after the treatment of the root canal, a new set of microorganisms has infected the root canals which were not the part of primary infection. Okay. Secondary infection is more specific. Okay. These are mostly multi-species or mixed infections, the primary infections of the root canal. Secondary are more specific, that a particular sets of bacteria are responsible. And persistent infection means microbes which are resistant to root canal treatment procedures, medicaments and procedures. Okay, whatever treatment we have done flushing of the root canals, we have used intracanal medicaments, but such microbes are not eliminated. They cause persistent infection which can be a part of primary or secondary genera of microorganisms. These are mostly species like gram positive, like Enterococcus and Streptococci. Okay, so three type of infections are there. Extraradicular infections from outside the root canal, they are produced by two main set of microbes: Actinomyces species and Propionibacterium propionicum. Actinomyces and Propionibacterium propionicum. Whenever there is primary infection of a root canal, it consists of 10 to 20 species of microbes. Okay, successfully treated root canals still consist of 5 to 10 species of microbes. They are never fully eliminated from the root canal. So infected root canal and a treated root canal, number of species, not the number of bacteria, but the number of species of bacteria which are present. They are, if we talk about acute abscess case or cases of acute apical periodontitis, AAP stands for acute apical periodontitis, then the most frequently identified organism is Treponema denticola. In cases of chronic apical periodontitis, it is Dilester inviscous. In cases of failed root canals, Enterococcus fecalis is identified. Enterococcus fecalis can be eliminated by in the potency sodium hypochlorite and chlorhexidine both. Okay, it cannot be treated with calcium hydroxide. CH stands for calcium hydroxide. It is resistant to the action of calcium hydroxide. The question is asking which antimicrobial is most effective against Enterococcus fecalis. Okay, then the first choice would always be sodium hypochlorite. The second choice would be chlorhexidine. Irrespective of the concentration of the solutions given, sodium hypochlorite is always more effective in eliminating E. fecalis from the root canals as compared to chlorhexidine. Calcium hydroxide is not effective. Okay, in the cases of flare-ups, in cases of root canals, the bacterial species commonly involved are Fusobacterium, Fusobacterium nucleatum, okay, Porphyromonas, and Prevotella. These are the bacterial species which most commonly called flare-ups. Flare-ups are mostly found in teeth like maxillary, lateral incisor, and mandibular first molar. Most commonly involved teeth with flare-ups. Fusobacterium is most often responsible for the flare-ups with the severest form of pain or swelling or both. Okay. These are some of the microbiologic aspects of related to endodontics. Periapical abscess, periapical pathology. There is bone resorption. Bone resorption is due to pro-inflammatory cytokines. Pro-inflammatory cytokines like interleukin 1, which is alpha and beta 2 types, tumor necrosis factor alpha, and interleukin 6. These are the principal pro-inflammatory cytokines which cause bone resorption. Out of this, interleukin 1 beta is most potent in causing bone resorption. These are the important aspects of your periapical pathology and microbiology. Then some things related to endo mishaps. Endo mishaps. They would give you figure-based questions about ledge formation, perforation, and zipping of the root canals. Means if there is a figure like this, with the root canal like this, okay, there is an extension of shelf formed in the root canal. This is ledge formation. Ledge is a horizontal shelf-like extension that prevents the passage of instrument to the full working length or the apical 1/3 of the root canal. This ledge formation, for this, if it occurs, it is a treatment like we have to use a small pre-curved file Okay, short of working length in watch winding motion. In watch winding motion, we have to use a small pre-curved K file to negotiate the ledge. Okay, so a small file is taken which is pre-curved like this, and then it is rotated so it would trace the entire wall of the root canal, and wherever we find a catch we would proceed forward. Okay, perforation means there would be a figure like this, apical perforation. The root canal, instead of constricted, it has become like this. It indicates apical perforation. There's perforation. Okay, if it is like this, ledge formation with zipping. This is ledge formation with zipping. Zipping basically means widening of the apical foramen. Okay. Prevention is by pre-curving the instruments. Pre-curving the instruments. These are the procedural errors during instrumentation of the root canals which happen, like ledge formation, apical perforation, and zipping. Apical perforation, it can be 3 grades: 1, 2, and 3. First is the simplest or the least severe one, which requires renegotiation of root canals. Renegotiation of root canals with larger files. This type 2 or grade 2 perforation, it requires MTA apical plug. And the most severe form is type 3, which requires surgical management. Okay. 3 type of apical perforations and their treatment methodologies. Okay. Repair materials and factors affecting the prognosis of perforation. Factors, whenever there is perforation, what are the factors? Factors from most important ones which affect the prognosis is time. The perforation in any case and every case should be repaired as soon as it occurs, because if we wait even for a single day, there are chances of formation of granulation tissue that would interfere with the successful repair of the perforation. So the most crucial factor which affects the prognosis of a tooth is time. Then the size of perforation, and then the location of perforation, then repair material. So the most important factor is the time which affects the prognosis of your perforation. Repair materials, they can be resorbable and non-resorbable. Resorbable materials, they are collagen and gelatin based. Okay. Non-resorbable materials, calcium sulfate or gypsum based, and MTA and similar materials. Non-resorbable are more favored. These are some of the important aspects related to endo mishaps related to the instrumentation of the root canals. Then there can be irrigation related mishap. Irrigation related is most common sodium hypochlorite accident. Means whenever sodium hypochlorite extrudes into the periapical tissues, it leads to rapid hemolysis, ulceration and necrosis. It is a medical emergency, has to be treated promptly. Okay, prevention. Prevention is passive irrigation. With closed ended needles. We have to do careful flushing of the root canals with closed ended needles. Most commonly used gauge is 30 gauge needle for irrigation of root canals. If the 30 gauge is not there in the options, 29 or 27 gauge in that sequence you have to answer. Okay, needle gauge. 30 gauge is the most frequently used. Needle is placed for successful irrigation 2 to 3 millimeters from working length. From working length means I would say above working length, or simply apex of the tooth. Okay, if both 2 or 3 are given in the options as separate options, stick to 3 millimeters. The needle tip should be within 3 millimeters of the apex. Okay, most important factor, volume of irrigant. Volume of irrigant. Okay, not the concentration of the type but the volume of irrigant, because we need to rely upon the flushing action of irrigant. Another set of questions, they ask you minimal apical enlargement related to irrigation is number size 30 to size 40 K file. Okay, because the smallest gauge of needle that is available is number 30 gauge. 30 gauge is 0.3 millimeter diameter, which is equal to the size of the tip of number 30 K file. So minimal apical enlargement is 30 to 40 K file. Okay, these are the important aspects related to prevention of procedural error related to irrigation of the root canals. Then we have another procedural error, that is CFSE, that is cervicofacial subcutaneous emphysema. CFSE, cervicofacial subcutaneous emphysema. This is called air entry into periapical tissues. Okay, at times after cleaning and shaping of the root canal, we dry the root canals and then we proceed with the obturation. But if we are drying the root canals inappropriately with compressed air with a 3-way syringe, then the air can enter from the root canal to the periapical tissues, and the subsequently what happens, it enters into the subcutaneous tissues, which is called cervicofacial subcutaneous emphysema. Okay, this leads to clinical signs. There is balloon-like enlargement of the face on affected side. Okay, no redness or inflammation. We can distinguish this swelling from swelling of inflammation because there is no redness, only simply enlargement. So it is normal skin color. Clinically, there is a normal skin color. Another clinical sign is presence of crepitus. What is crepitus? Whenever we palpate such inflamed tissues with hand due to air movement, we feel crepitus, bubbling or gargling sensation, that is called crepitus. These are the two clinical signs which help in distinguishing this air entry from that of sodium hypochlorite entry or any inflammatory episode which has occurred. Okay, this air entry, massive air entry, it can reach from facial tissues okay, it can go up to the pharyngeal tissues. There are tissue spaces continuous from the face to the neck to the pharynx, and from pharyngeal tissues it can enter into mediastinum. This condition is called pneumomediastinum. It can enter into the mediastinum and the condition is called pneumomediastinum. Okay, it is a medical emergency. Just like entry of sodium hypochlorite into the periapical tissues, massive entry of air from the root canals can enter through the subcutaneous tissues into the pharyngeal tissues to the mediastinum, and that can cause choking of the patient. So this is called pneumomediastinum, and it leads to a characteristic clinical sign called Hemmen's sign. Hemmen's sign means we see air gurgling is thereon, is heard on stethoscope. Whenever we place stethoscope on the patient's chest and the mediastinal region, we see sound of air moving up and down, vigorous sound, that is called Hemmen's sign, and which is a characteristic feature of pneumomediastinum. So it is a medical emergency, has to be measured, I would say has to be taken care of promptly. So these are the two mishaps related to entry of irrigants and air into the periapical tissues, CFSE, and the sodium hypochlorite accident. These are the common things about your endodontic mishaps. I think these are some of the important aspects in the past 2 hours I have been able to summarize with related to the high yield facts of your endodontic. And with this, I wish you all the very best for your forthcoming examinations, which is scheduled on 18th of March. Be focused, be confident, and be positive. Whatever effort you have put in is more than enough to secure a good rank in the NEET Pre-PG examinations. With this, I am signing off. My best wishes to one and all. All the very best, dear students. Thank you so much for being with me.